Good evening. So today we are going to continue from where we had stopped. And before you again, it's me, Dr. Edrisa Mutebi. I specialize in endocrinology, particularly diabetes. I'm also an epidemiologist, and I'm a physician as well. I work with Makerere University, and I head the endocrine unit in Mulago Hospital and the College of Health Sciences. So today we are going to continue. For those who have just joined into this, last week we had an extensive session where we extensively discussed the initial parts about diabetes. But just to give a quick recap, we defined what diabetes is, and we totally explained what happens in type 1, type 2. We looked at the different risk factors for diabetes, and then we looked into the diagnosis, and then we went into, tried to go into detail a bit about the treatment. Where the treatment, we discussed the different aspects, particularly focusing on diet, exercise, lifestyle aspects. And today we are mainly going to now focus on the next part that members thought we could also go into that bit about the treatment. So within the next to the drugs that we use, and then we shall look a little bit in
Doctor, I think we're losing connection. Doctor, we must be frozen. Oh, it just went off. Okay. Doctor, we lost you there. Unmute yourself, doctor.
So really sorry about that technology shortcoming, but what we had said is that we are going to look at these different aspects. Today we are going to focus mainly into the goals of treatment, drugs, complications, and then the follow-up. Diabetes is very wide, but I try to really highlight a few things that we should be comfortable with moving forward. So the goals of treatment. As we manage patients with diabetes, it should be very important for us to note that this person should lead a normal life. They should have a normal life that should not be interrupted by any of either treatment or the lifestyle or the exercise. So we should ensure that this person is leading a normal life. The number two, we should attain a stable sugar level within the blood. Because if we don't have normal levels, eventually what is going to happen, we are going to get damaged, just like we saw the part there is that is supplied by blood. So we want to also want to pay drivers for the complications, particularly our high blood pressure. We want to minimize the complications. So still continuing with the targets, as we manage patients with diabetes, our goal is to have an HbA1c of 6.5 by and large. We throw in For example, we may relax this figure, and we may want somebody to be at 7.5 or somebody 8%. And those ones, because these ones you don't want to be strict with them because they can quickly go into hypoglycemia. We have to, number two, patients got multiple organ damage, quickly keep them in the low levels because two are at risk of hypoglycemia. Again, the extremity of life. The very elderly, because especially the very elderly, they will get what we call hypoglycemia unawareness. They go into when they don't know. So really those ones, we want relaxed HbA1c. And then the patient has so many years ahead of them, so you don't want to be too strict on them. So patients who are elderly or very young, we entertain anywhere between 8%. Other patients, 6.5, HbA1c. And HbA1c really is taken over the past 3 to 6 months.
Doctor,
and,
forgive me for
we're
interrupting.
able to evaluate.
Doctor.
Yes, please.
We are network.
Yes, please.
We are struggling with hearing you today. Network Sinonji. We keep missing the part. So can we take
And
the video
what about
off?
there? Is that okay?
You have to talk maybe for like a couple minutes, maybe a minute or so. Pull it over your network because we keep missing a few parts in what you're saying. Over we take the video off.
My video, I think, is off. Are you still seeing my image?
Yeah, we are. Yes.
Okay. What I could do, I could.
Well, I think now you're sounding a bit clear.
It's clear now?
I guess. Let's see what happens.
Okay. So just like we have said, target HbA1c 6.5.
Doctor, share that. A message here is mixed with Luganda, please. Some technical
mix it a little bit?
Yes, we're going to mix.
Okay. Essentially, what we are saying is that sukari tuba twetaaga okumumonitoringa and okulaba nti control yaffe ennungi. Kati buli myezi 3 ku 6 tuba twetaaga tukole test gye bayita HbA1c, which tells us nti sukali waffe ali bulungi wano. Kati ku muntu ng'akyali muto tukozesa HbA1c eya 6.5 ebeera nga target yaffe. However, omuntu abeera nga mukulu obanga abaana bato nnyo obanga alina ebintu ebirala ebyonoonese mu mubiri, then tumanyi okurelaxinga mu HbA1c eno tukiteeka ng'eri wagguluko negenda nga ku 8. So that abantu abo sukali tabagwamu nga tetumanyi. Okay, so we also have other things that we can use to monitor the sugars. So, for example, to use our ordinary sugar that we test. And for starters, number 1, we need to do the 2 hours after a meal. And there our target is 180 milligrams per deciliter. Then number 2, we can also use the fasting blood sugar, which normally is the sugar that we do 8 hours before a meal. And our target there is 80 to 130 milligrams per deciliter. These 2 readings are very important in addition to the HbA1c, because the sugars, the 2 hours after a meal, or the fasting blood sugar, all they are doing for us, we use those to monitor, just like you monitor a program. But the HbA1c does what we call the evaluation. So in other words, the day-to-day running of our sugar, the information we shall pick from the 2 hours after meal or the fasting blood sugar. And the HbA1c will give us the evaluation. In other words, after this long period, how are we doing? That's HbA1c. On a daily, what are we doing? The random sugars and the fasting
Doctor? Oh, today we're struggling with network. And last time it was okay.
Also, I think he should take his video off.
Okay.
Enkuba etonnya
Yeah.
Uganda.
I thought he had said he was off, and I'm okay, Kanda. When they seem to be getting better. He has come off completely. Katulindeko. The correlation between Nkuba network.
Anti wabeerayo kibuyaga. Mudaga, we now have to bring technicians to tell us. But I also, in Cuba, with network in Uganda, that's what happened.
I know. Just to be nga byannako. Baasima ne bakola fiber optics ne basima ekibuga kyonna nga bakola fiber optics. Namanyi ebyo byonna bijja kugenda.
Bw'aba baazikola.
Oops. So katugumiikirizeko please, Dr. Like a network. Please bear with us.
Mr. Hasfa, waliyo gwe omukono oba akugye.
Gezaako getting a doctor to log back in. He's having a little bit of a network issue. Please be patient. Okay, doctor is trying to log back in. Please bear with us a few minutes. Yeah, Dr. Gambia is having, oops, sorry. Sorry about that. A doctor is still having a problem. He's trying to log in, but he's having a problem of a network issue in Uganda. Sister Nilfa. Nilfa.
Hello? Yep.
Ogira otwalirizaako ku class katono nga doctor wakola ki?
Gitwala mu ki? Sisobola kudisituta gundi.
Ogira otuwulirayo ebitonotono ku bya sukaali oba recap of last class.
Oh, it was a recap of last class. Okay, I'll just, it's better if someone asks questions. If they ask questions, then I try and answer as much as I can. All to let people know, we're to sum about diabetes. Really issue called diet, to discussing about the diet, abantu chebayinokola. Then to go a doctor to really on a treatment plan, because as we all know, we are getting problems with abantu bafukumanya chebalya kusukali ne chebatalya no butamutya nnyo ne issue endala eyaliwo twamugamba yogereko ku the herbs, because people are being bagenda into new these herbal therapies which are actually being detrimental to their health, ekitali kirungi ku sukali. Oh my, and I'll see if I can try and answer as much as I can. Ngabotulinda doctor.
Yeah, okay, inshallah. Kati mwabitugoba ku kigaji neofa. Ekigaji bagamba nti kikaawa. When I drink herbal medicine like kigaji chikawa, there's another plant in cherabide. Bagamba kiyamba ku sukali. Should we only stay to the Malagala Makere and Agabazungu? Or we also try a little bit of the
with diabetes, actually, it is actually your diet. It is your diet and how you're doing it and control. Mire dagale zungu. Anti ishe want a dagale zungu mudiva with the herbs as well. Ne echigajo kawa, you're just having the green bit of it. The aloe vera, the inside bit of the aloe vera, I think, has more benefits than the actual green part of that thing. I'm not a herbalist, so I'm not really sure. Now, as doctor said as well last time, now there's an issue of underdosing and overdosing. And the issue, what they have mixed. Because buli muntu habo akola akakebe n'ateka kwa akakebe. Nakuwira with tebamanyi kiki bataddemu. That is the issue.
Brother Ali, unmute yourself.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullahi shayad.
Thanks for kubawuliza, alhamdulillah. Ekibuuzo ekyange kigenda kubeera kyangu nnyo. Tubiraba kikavalinga naye leero lwe mbaddeko.
Shay obuze. Shekali obuze sir. And he still has the mic.
Is he okay?
Yeah, I think he got a call. Shekali. His mic is still open.
Okay.
Yeah. Doctor probably still also struggling. Omanya, I just remembered Neofa during COVID time, he's also come off. During COVID time, abantu bagamanga munyoe tangawuzi, mutekemu, obutungulu ne garlic, and then people got never bleed because of the herbal.
GI bleeds because of that.
People
were not knowing what was going on, and instead of people getting proper treatment,
yeah,
or for proper treatment, and they had it in their mind that is the medicine.
Yeah.
Those are just sort of like supplements.
Yeah, the ginger and the garlic. Shekali unakomeo, Shekali sewa nkwada kazinda.
Alhamdulillah. Bana ekibuuzo kyabadde kyangu.
Yes, sir.
Angamba nti muyinza okuba mwakiddamu dda naye saaliwo. naye nga kintawaanya nnyo okumanya sukaali, relationship ya sukaali okumuyita ffe sukaali. Abazungu ne bamuyita diabetes. Ekituvaawa ffe okumuyita sukaali oba era sukaali kyoyo gwe twogerako.
It's a very good question for doctor today.
Yeah, kuwachi for twamwita sukali. Kale.
Bakujja ku sukali.
Simanyi lwaki bamwita sukali. That is very interesting. Inshallah kacherekere doctor, hopefully again network egenda kuddako very soon. Inshallah. But thank you for being patient. The doctor, the network is still struggling a little bit.
Abuze ku Imam Kasozi.
Ndekadde ufa Imam ajja wali wano ojja kumusiikuula. Ama Imam ekyo nze sikyogedde.
Abafuna advice kye yakola Imam wange. Agenda tulya.
Network emawanga yateera, but maybe ngeri gy'ogambye enkuba etonnya. It could be the rain. Banaye tugumiikirizeeko inshallah. Is trying to log on. Yeah, so Nilfa, so we cannot do a lot of herbal medicine or kujjanjaba sukari.
Not even sukari, so many conditions. Because actually these herbal medicines are actually leading into things like gastric and, gastric problems. So many things are happening. Kati ojjukira concoction ya COVID.
Yes.
Ngabajiwa n'abaana, a 3-year-old.
Oh yeah.
And you see all these kind of complications. Na issue where Uganda and buli herbalist, buli kaduka kotambula ola container of white or what. No gamba Arab. Nze navanga kuddaga ezungu nze nywa habo. Nofunako kati abaana kati abatandise okunywa enjaga. They're like opioids just in there.
CBD.
Yeah, but now it's this is beyond CBD because I'm telling you, my sister.
CBD. Okay. Alhamdulillah, Dr. Uno is logging back in. But CBD has been known to be used okujanjaba ebintunga seizures, chronic pain. Yeah. So
I'm telling you, it is now
the co-host.
It's now the medicine for everything.
Yes. Sorry about that. Sorry about that. I don't know what happened. I don't know what happened, but all of a sudden my system went off. I couldn't. So are you able to see my slides?
Not yet.
What about there?
Not yet.
Let me go back to sharing. Where is I don't see the I think you may have to accept me. Okay.
We already made you a co-host, doctor, so you can be able to share.
Okay. Then it should be okay now.
Let's see. It says, okay, we are on.
It's on now.
It's on.
Okay. What I'm going to do, I may not broadcast my video because probably the video slows down the computer.
That's okay, doctor. So not question and answer.
Okay, so just like we were saying that as you select the drug to use, you should be able to consider the cost, the lifestyle of the patient, because this person may be traveling and they go up country, they work, do hard work, maybe muchikubo, so you have to really consider the lifestyle of the person. Then the weight gain. Different drugs will make you either gain weight or lose weight. So if somebody, babanga munene, you don't want to use a drug which is going to make them gain weight. And then you consider the cardiovascular effects. We have certain drugs that may affect the pressure, may affect the vessels. So you consider that as well, as you're going to see. And then the side effect profile of the drug. So you don't want to give a drug that has been noted to have side effects. For example, metformin may give you a little bit of a tummy upset. So toyagala mukozesa nga omuntu already has tummy issues, vomiting, diarrhea. So you may want to use other medicines. And of course, you want to consider the other illnesses the person has. If somebody has, say, asthma, or somebody has got other illnesses, then you may want to rethink the choice of drugs you're using. So number one, about the drugs, we have a group called sulfonylureas. Now, this may sound a little bit too technical, but in there we have drugs that stimulate the pancreas. For example, we have glibenclamide, we have glyclazide. Now, those are the examples. And essentially, this group of drugs, all they do is to try and stimulate the pancreas so that it is able to produce our insulin. Remember, we said we have a group of patients who have got an issue about insulin, they lack insulin. So this one tries to stimulate production of our insulin from the pancreas. However, they may cause hypoglycemia, and they are also notorious at causing weight gain. So if somebody is obese, you don't want to use this group of drugs. And then the older generations, glibenclamide is generation 1. So glibenclamide was noted to have some effects on the heart. And these days, we rarely prescribe it. So that is one group. Essentially, they work at the pancreas to stimulate it. Okay, then we have another group of drugs called the bigonides. And an example here, we have metformin. Metformin is one of the widely used drugs because it is very safe in terms of side effects. And essentially, all it does is it increases the insulin the body produces so that it works very well within the tissues. And we call it tissue sensitizer. And it's one of the drugs that lowers HbA1c by 1%. And essentially, it also regulates the glucose that pours into the body. It goes to the liver and instructs the liver that, hey, come on, I don't want glucose in the system. So the liver will hold onto the glucose it has, store it, and you have less of the glucose in the saturation. And it is also known to cause loss of weight. So if somebody is thin, you don't want to use metformin because it is going to thin them further. So you may want to reduce the dosing these patients are using. And then we have another group of drugs. Remember, glucose only rises by what we have eaten. So we have a group of drugs called the alpha glucosidase inhibitors. And an example there is acarbose. These drugs, all they do, they go to the intestines and instruct the intestines, hey, come on, slow down the rate at which you're absorbing this glucose. So that in the body now, you don't get that quick rise in the glucose. These drugs cause a bit of gas in the stomach, flatulence, they cause abdominal discomfort, and they're also known to cause weight loss. We have also another drug group called the thiazones. Thiazones is also a very good class of drugs because it, just like metformin, it works in a way similar to metformin because it's our insulin very well in the tissues. However, they have one problem is that they cause fluid retention. In other words, if a patient has got a condition like cardiac failure, they have got high blood pressure, they've got a problem with the kidneys, you don't want to use pioglitazone because it is going to cause them to retain even more fluid within the body. And they also cause a drop in the calcium in the bones, what we call osteoporosis. So if a patient is going to be on pioglitazone, one has got to be cautious to make sure they monitor the calcium, monitor the bones to ensure that these patients do not get low calcium levels in the blood and also in the bones. Because if that happens, then they can easily break the bones when they get a simple knock on the bones. And it also causes, they cause a bit of weight loss. So generally in diabetes, as we focus on the sugar, most of these drugs also have an effect on our weight. So as we give you these drugs, we also look whether it is causing weight gain or loss in weight and other things it causes in the body. Then we have, now these are really newer medicines, the DP4 inhibitors. An example is vildagliptin, saxagliptin, sitagliptin. They're all examples. At times we call these the gliptins. And all they do in the body is they sort of like increase insulin through stimulation of a chemical called glucagon-like peptide. Basically, this is a complicated group of drugs, but all what they do is to reduce your appetite, so you eat less. They also stimulate in a way insulin production and lower glucagon. So what they do, they try to decrease the hormone which would increase your glucose levels, which is glucagon, and stimulate insulin, which will reduce your glucose levels. But they also have a little bit of an effect that they cause a drop, not a weight gain, but a drop in your weight. And they also cause a drop in HbA1c of 0.6 to 0.8. Remember, metformin, we said, causes a drop of 1 to 1.2%. So really, metformin is still superior to this group of drugs. Now, we have another group that is called basically GLP analogs. It's also technical, but all what this group of drug does is that it also reduces your appetite, increases insulin production, but the downside to this drug, I don't want to call it a downside, it is an injection. But the advantage is that you can get this injection once per week. So you get one injection and you're done with it. And all it does, it goes into the body and stimulates your insulin, reduces your appetite, so you eat less, and at the end of the day, drops your glucose levels in blood. Then we have another group which we call the SGLT2 blockers. Now, in the intestines, we have channels that lose glucose in urine. Normally, the body doesn't want to lose good things. So what it does, if you have too much glucose in the body says, no, I still want this glucose. So it retains the glucose inside the body. So God created us with a certain channel that reabsorbs that glucose back into the blood. Now, this group of drugs, what they do, they block that channel. So you don't get reabsorption of glucose. In other words, what they do, they stimulate loss of glucose in the urine. So you lose lots and lots of this excess glucose that's in your blood into the urine. The downside to that is that these drugs can predispose you to urinary tract infections. So patients who are taking these, we normally monitor them for infections. And basically, they also get periodic bladder irritations. So we must monitor them in case of any bladder symptoms that they develop. And important to note that this group of drugs also have a huge benefit onto the heart. They have actually been licensed to be used for high blood pressure. And an example is dapagliflozin. So these drugs do two things. One, they control your sugar, but two, they also protect your pressure, your cardiovascular system. This is a very, very, very good group of drugs. And usually these days they are combined with metformin to even give us better effect on the sugars. Then we move down to the one that most people don't like to hear about, the insulin. Now, insulin is the only drug that, in addition to the GLP analogs, insulin is one drug that really comes close to what we have naturally in the body. And it's basically you're saying you don't have this hormone, let me replace it. And we have essentially 4 major types. We have the rapid, the short-acting, intermediate, and the long-acting. Now, all these are different forms of insulin that we have in the body. And we adjust these different types to try and mimic what happens in the body in the natural, in the usual setting. So number one, if somebody has not eaten any food, the body will keep producing what we call basal insulin in the body. For example, if you're fasting, say in Ramadan, or you haven't had a meal, your body will still produce glucose, which helps to sustain the different systems, even when you're fasting. Then number two, when you take a meal, you get a boost in the fasting glucose. Now you get a surge in glucose whenever you take a meal. So that's why you see they develop the different types of insulin to try and mimic that. The long-acting insulin mimics the fasting glucose. So when you are fasting and that glucose is at basal, we use the long-acting insulin. And then the rapid, we use it whenever you have a meal. When you have a meal, we give you. You have a meal, we give you. You have a meal, we give you. So if you have 3 meals, we give you 3 shots. However, these insulins, over time, there's been modifications. And now in Europe and in America and in developed countries, of course, in Africa, it's still slow. We have what we call the automatic pumps, where patients get a gadget, they connect it onto their body, and this gadget is able to measure the glucose, and it automatically injects the appropriate insulin that is required by the body. So it sort of like becomes like an artificial pancreas, because the pancreas does that role. But now you have created something that mimics a pancreas, and it is totally automated. And of course, new gadgets have come up where some of these are even connected to the smartphone, that it can communicate with the phone and sends in information to tell you how your sugars are ranging. But by and large, insulin, we bring it in to try and replace the hormone directly. Then, what are the benefits of insulin? So number one, insulin has been known to be the masterpiece in terms of controlling our sugars, because insulin does almost close to what the body would have done. So it is a masterpiece in terms of controlling our sugars. Unfortunately, most patients, once you tell them we are going to put you on insulin, they feel that, oh, this is the end of the world. But it doesn't mean it's the end of the world. It is one of the big bullets that we use if things have gone out of control. And then the downside to it is that it causes a bit of weight, increase in your weight. And then the side effects, other side effects, is that somebody has got to be very cautious, because you can easily go into hypoglycemia. And the hypoglycemia caused by insulin can be very rapid and can quickly progress. So somebody has got to be very cautious as they use the insulin. That's why I tell my patients that whenever you are using insulin, try and don't take it beyond 8 p.m. because you don't want to go into hypoglycemia when you're sleeping. So it's better you take it in farthest 7, 8. And then, of course, the pricks are very uncomfortable. And it also causes changes in the way the fat is distributed in the body, as it gives you the weight gain. So when do we start insulin? Who are the candidates that we say that, okay, this person needs insulin? If somebody has got type 1, diabetes. Remember, I told you that if you can see that image on the right, remember we had said that patients who have got type 1, the pancreas does not produce that insulin there. So those ones are telling you that, hey, I need this insulin because I don't have it in the body at all. And if a patient comes and we have started them on oral tablets, we have started with one tablet, then we have added on another type, and we add on a third type, and they come back after excuse me, 2 to 3 months, and there's no change, then those are candidates where you start insulin. Excuse me. And then there are patients who come right away. You do their HbA1c and it's above 9%. Some literature will tell you 10%. Those you start insulin right away. And once you control the glucose, you can always track back onto the tablets. So it doesn't mean that whenever you use insulin, you're going to hang onto the insulin alone. If you're doing well, you can always switch back to the tablets. And certainly patients who have got complications, we start them on insulin so that will minimize the damage. Now we move into the complications. So just like we saw last week, complications of diabetes mellitus are caused by a rise in the blood sugar. Once we have this rise in sugar, it causes substantial damage in the body. And normally this process is also supported by uncontrolled high blood pressure, obesity, smoking, alcohol, sedentary lifestyle. And of course, if you're taking inadequate medication, some patients, you tell them take 2 tablets in the morning, 2 in the evening, and some days they don't take, others they skip. Now, these factors, together with the rise in the sugar, they quickly fuel the complications within the body. And we said, majority of this complication occurs within the vessels. So you're going to damage vessels all over the body, right from the brain, the eyes, the heart, the lungs, the kidney, the liver, the blood vessels, the nerves. Just like we saw last week, every other part of the body is going to get damaged. Now, into the complications, now we can split up the complications into what we call the acute complications and then the chronic complications. Acute complications, we have hypoglycemia. Now, hypoglycemia normally comes in if there is, in the body, we want balance between the glucose and the medicines. If for whatever reason, the medicines overpower how much food you have eaten and you get an imbalance in there, you go into hypoglycemia. If the medicines are excess, more than the glucose in the body. That's why as we give you medicines, we try to monitor to see that we are balancing between the 2 sides. Otherwise, if we have too little of the glucose, then you go into hypoglycemia. Hypoglycemia, that is a state where the sugar in the body goes below 30 to 50 milligrams per deciliter. And normally what happens, these patients will develop features that will show that they're very, very hungry. They start to get tremors, they start sweating a lot. Some of them may go into coma. They feel like they're going to die the next minute. They become restless. They get all the shivers. The heart starts running fast. So once a patient develops those, we quickly have to give them glucose at whatever means, whether we push it through IV, whether we push it through the food, whether we give it as a bolus. So we have to ensure that we push in glucose. At times we advise them to take a soda. If there's maybe sugar, you can quickly mix sugar in a cup of tea and force it down these patients. Now, it's always important to note that patients at times may go into hypoglycemia without you noticing. So it is something that we normally have to look out for, especially as we administer our drugs. That's why we encourage our patients, whenever you are taking medicines, you should have a glucometer. And if you're not feeling well, run a sugar. And if you're not sure, for example, some people don't have glucometers. If you're not sure whether the sugar is up or low, assume it is low and take a soda, because low sugar kills. High sugar kills, but it will kill you after so many days or after so many months, because for it will go through a longer process. But hypoglycemia will knock you down very quickly. So if you're not sure which side you are, please take a soda. And if it is low, you will actually see yourself improve right away. Then the second complication are the hyperglycemic complications. Normally these come about because now the food is too much in the body, more than the medicines. And we have two categories, and of course these are medical terms, but just know that really these come in if we have too much glucose in the body. Now, diabetic ketoacidosis, what we call DKA. Now, that one occurs in patients who are relatively younger, and they still have some residual, the body tries to sort of like break down fats. As it breaks down fats, it generates acids. And these acids get into the body and cause the body to get into this, that state of emergency, where somebody goes into coma, they start sweating, they may vomit, they may get abdominal pains, they may get very sick. They start running a fever. Actually, may think they are having some infection, yet it is acids caused because of the too much glucose within the body. We have another type which we call the hyperosmolar non-ketotic states. Of course, also that is medical, but essentially this second type is normally occurs in elderly patients. And these elderly patients normally have got dehydration because of the too much glucose in the body. They become dehydrated. They start taking too much glucose, rather water. They pass out too much water. And because of the hypovolemia and dehydration, these patients may also go into coma, become very weak. Now, these two forms of emergencies that occur when the sugars go too high are life-threatening. All the three are life-threatening, hypoglycemia more than these other two, but all of them are medical emergencies that we quickly have to think about whenever a patient with diabetes either develops features, either they are running a fever, they're sweating a lot, they're vomiting, they're having abdominal pain, they get alteration in the meditation. We quickly have got to intervene. And this can be detected if somebody runs a blood check. Treatment of these two requires that we give the patient insulin. We normally use rapid insulin, so that will bring down the glucose. Number two, we have got to check their electrolytes. Notorious is potassium, which we have got to deal with. If the potassium has got any issues, if it is low, we have to give these patients potassium chloride. If this patient, because of the acids in this category, these patients may come in with very, 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 very high acids within the blood. We give them bicarbonates to try and settle those. But by and large, those things we do within a hospital setting. These are normally handled within the hospital. And also they are dehydrated. So we have to take care of the dehydration. Most of the time, they lack between 4 to 6 liters of water. So we have to ensure that they drink or give it to them parentally. There's so many people will ask you, how much do we give in terms of the liters? But by and large, monitor that particular patient before you. Monitor their pressure, their pulse, see how much urine they're putting out. If somebody is dehydrated and you rehydrate them very well, they should start passing out urine. They should start to have mucous membrane should be moist. So you have to use features like the pulse. The pulse should come down if you are better hydrated. Your blood pressure should improve, because if you are in low volumes, the pressure goes down. So as we rehydrate you very well, the pressure should improve, and then you should start passing out urine to show that the system is now well hydrated. So number 3, we said number 1 was the insulin. Number 2, we said you have to take care of the potassium. Number 3, we have to take care of the acidemia by giving them bicarbonates. And then number 4, we have got to give them normal saline to try and replace the fluids that they are lacking. Some of these patients, people try to use Ringer's lactate, but we can't use Ringer's lactate in these patients because Ringer's lactate will worsen the situation. The best drug for us to use is normal saline. So next, we now move into the other complications. There are really so many, so many. But one, patients with diabetes mellitus, just like we discussed last week, have got a problem with their immune system. So they are going to keep getting recurrent infections, upper respiratory tract infections, pneumonias. They keep getting pneumonias. They keep getting skin issues, skin infections. They keep getting UTIs. So if you see a patient with recurrent infections, it will be nice to screen them for diabetes. And particularly the patients who are poorly controlled, they normally get infections. And how we manage this, you need to take a sample of the particular system that is affected, get to know which appropriate antibiotic you need, but most of the time we use broad spectrum antibiotics for these patients. Number two, we go to the brain. These patients are prone to getting strokes. And all we do, if they ever develop a stroke, we need to give them supportive care. In terms of 2-hour returning in bed, we have to mobilize them, move them. We have to try and make sure that they are not lying down and sleeping all the time. So we try to mobilize them and also take them to the sun so that they get some vitamin D, just like we saw last week, supports the different body systems. Hypertension and cardiac failure. Hypertension are two things that are going to worsen your diabetes. So we need to have our pressure controlled. And our target pressure is normally 130/80, rather 130/90. And then in here, we need to also use drugs that will control our cardiac failure. I told you about the SGLT2 inhibitors, the dapagliflozin. I told you those drugs that are going to stimulate the urine to be lost in the urine. So these are important drugs that we can use to help us with the high blood pressure, cardiac failure, at the same time help us with the sugars. Beta blockers, drugs like carvedilol, bivalol, metoprolol are also going to be important in controlling your pressure and cardiac failure. Then peripheral artery disease. This is another complication which occurs a lot in patients with diabetes. These patients will normally come in with burning of the feet. The feet become darker and they become cold. So these patients, most of the time, we give them aspirin. Aspirin helps them so that the blood moves better. Peripheral artery disease is really like the blood is not moving well in your legs. So the legs become dark and they are prone to getting wounds. So we give them aspirin and we give them a statin. And particularly we normally use rosuvastatin. That is a very good statin. And both of these, they help to improve flow of blood through the vessels. We also use another drug called pentoxifylline, which is really a drug also to vasodilate and help blood move better. But of course, if it is too advanced, at times we call in the vascular surgeons to try and do surgery on those vessels and open them up. Then we have peripheral neuropathy. Peripheral neuropathy is really when you have vessels that supply nerves being affected and eventually the nerves start dying. Here the patients will come in with pains, which are in the distribution of glove and stocking. They'll have pains in the fingers, pain in the feet. And these are really because the nerves are complaining because they're not getting blood supply, okay? And most of the time here, essentially what we do is to try and one, control our sugars, two, control the pressure, control the cholesterol, our exercises, the lifestyle. And here is where we bring in our drugs that help us control pain within nerves. And we use drugs like carbamazepine, we use amitriptyline, we can use pregabalin, gabapentin. Those are different drugs that we use to help us with the nerves. But more importantly is to control the sugars so that we minimize further damage. The nerves also predispose our patients to getting diabetic foot, as we are going to see. Gastropathy, this is really a technical term, but gastro means stomach. So it's really the stomach. And all we are saying is that if the nerves going to the stomach are damaged, these patients are going to come in with constipation. So once you have a diabetic who comes in with constipation, belching, they get all this gas in the stomach, they get flatulence, it is a sign that the nerves that supply the stomach are getting damaged. And we normally give them, just like the neuropathy, we make sure we control the triggers that are going to worsen these. At times we give them drugs that soften the stools, lactulose, bisacodyl, but also encourage them a lot to take the veggies, okay, the cabbage, the carrots, the buga, nakati, katukuma, all those to try and soften our stools so that they move smoothly. Then if we move down the bladder we have retention because the nerves have been damaged. So these patients are not able to urinate very well. So they retain the urine. They go to urinate and they cannot urinate. On the other side, some of them get damaged and they end up with incontinence. The urine just comes through. And some of them get recurrent infection in the bladder. And by and large, control of these, we try and put them on broad spectrum antibiotics to treat the infection. We also give them drugs like amitriptyline helps to reduce on some of these effects. But more importantly, any of these neuropathies, we also try to give them drugs that improve vitamin B12 in the body. Vitamin B12 is a drug that supports the nerves. So in addition to treating, giving them the appropriate treatment, we also give them something that improves vitamin B12. And there are so many on the market to try and help our nerves. The sweat glands, on the other side, our patients, sweat glands are supplied by nerves. And once these nerves are damaged, these patients stop sweating. People are out there and they're not sweating at all. So normally what we do, these patients are actually predisposed to getting diabetic foot because now they're not sweating. Remember that sweat sort of smoothens the skin and lubricates it and makes it so that it cuts down on the friction. So you are not prone to those infections. Once your glands are not producing sweat, then you are at risk of forming, getting a diabetic foot. Then erectile dysfunction, we are going to discuss that in detail in a few slides to come. Okay, then we have diabetic nephropathy. Really, this is damage down to our kidneys. I normally tell my patients that one of the biggest complications, one of the most scaring complications, one of the complications that I don't want to tell a patient they have developed is diabetic nephropathy. This is really damaged to the kidneys. The kidneys are gone. Once they are gone, it becomes very hard to manage them, to treatment becomes very expensive, very hard. It is more like game over if you develop diabetic nephropathy. We try to do things here and there, but we conducted a study in Mulago and most of our patients do not survive beyond 5 years. The maximum we have got is 5 years. Abalwadde ababeera ne ssukaali ekintu kye tusinga okweraliikirira okubeerawo ensigo okufa kye tusinga okutya. Ensigo senga zifa omulwadde oyo aba muzibu nnyo 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 ozizza engulu. And most of them kasa tutuukako eyo stage obujjanjabi bufuka bwa bbeeyi nnyo gamba ensigo si nnyangu kujjanjaba. Twagezaako okunoonyereza emulago okulaba abalwadde bameka abasigala nga bali bulungi nga bakyali balamu ng'ensigo zimaze okufa. Mu myaka 5 twali tetulinawo n'omu yaliwo. So ensigo abalwadde bange mbagamba nnyo ensigo kye kintu kyensinga okweraliikirira ku balwadde ba sukaali. Ensigo bwe zifa obulamu bubeera obulamu budito, I don't know how to say it in Uganda, but life, the quality of life, obulamu bwo bukyukira ddala, buba bukkiridde ddala nga buli ku nkomerero. So tetwagala kibeerewo. So tugamba nti no, obulwadde buno obw'ensigo tuyinza bulaba tutya. Number one, how we can quickly detect nti ensigo zaffe zifunako effect, tukozesa omusulo. Netugukebera akantu kano bakayita microalbuminuria, tukebera proteins oba ziliikinga. Now this is the quickest indicator ke katubuulira omusulo. ate kano katesi sikwekebera omusulo okwa bulijjo. Wano omusulo tubeera tukozesezza special test that looks at this urine okulaba nti no ensigo zaffe zikyakola bulungi. In addition, tukola ne test gye tuyita, just like we saw, we do renal function tests. Ne tukosa creatinine, ne tulaba ensigo zikola zitya. But the first indicator is this microalbuminuria. Then if there is a problem with the kidneys, we normally give you what we call the ACE inhibitors or the calcium channel blockers, or in combination. An example here, we have captopril, we have enalapril, lisinopril, and then the calcium channel blockers, we have amlodipine, we have nifedipine, we have verapamil, we have different drugs in there. So we use these medicines to try and improve the filtration capacity, the flow of blood to the kidneys, and also the filtration capacity of the kidneys. And remember, to try and prevent our kidneys going down, we try to control the sugars, the pressure, the cholesterol, the obesity. Those four have got to be controlled. No herbal medicines. One of the key things that is damaging our kidneys are herbal drugs. Herbal drugs have contributed a huge proportion of our patients coming in when the kidneys are damaged. Abakozesa eddagala lya habo zoonoona ensigo, abalwadde bajja ng'ensigo zimaze okwonooneka. Kibeera kizibu nnyo omulwadde okujja ne mugamba nti ensigo zo zaafudde, nange kennyini nfuna back effect. Mba nkigamba mulwadde nange kinkosa. So let us try not to use herbal medicines because our kidneys are going to get damaged. Ensigo bwe zigaana okukolera ddala, tuba tugenda kukola dialysis. Dialysis emulago buli session tugikolera emitwalo nga 5. Baba balina ogikola almost emirundi nga 4 buli week. Kyakitegeeza omulwadde yeetaaga close to million nga 2 buli week. Ate ezo million 2 kuliko eddagala, kuliko test z'okola, kuliko biki, ogenda okugirooti nga cost epaalukidde ddala. So twagala byonna bye tukola byonna tulabe nti ensigo zaffe tuzikebera periodically to making sure zikola bulungi, tetwagala kubeera nti zoonooneka. Okay, then next we have the sexual dysfunction. Sexual dysfunction, this can occur in ladies and men, and of course depending on what sex is affected. For the ladies, just like we said, diabetes will affect the lubrication within their system. It will affect their libido, their drive. They will feel that they don't want any sexual activity, and then it may affect their cycles. So they miss periods. And again, we said this is because of damage to the vessels. Mubasajja okusinga oli ajja kugamba nti munnange musawo amaanyi gange gakenderera ddala, oba agambe nti musawo wenneegatta n'omukyala ngendayo round emu mangu nnyo nga ntuuse gye ŋŋenda, oba nagamba nti no musawo, when I finish the first round I'm not in capacity to maintain a second one or a third one. So they also lose libido, the men, and it is also one big depressing complication that occurs in our patients. Very depressing. Some of them totally lose the drive, which can be very depressing. So in terms of management, tulina making sure, again, sukari are well controlled. Maybe there are pressure, amasavu, omwenge, okunywa taba n'omwenge, ebyo byonna byonna bisobola okuaffectinga amaanyi g'ekisajja. Tulinako again amadagala ag'enjawulo tuyinza okubeera nga tugakozesa okujjanjaba pressure, naye ne gakendeezaako ku maanyi g'ekisajja. So doctor waalina okumanya nti eddagala lino bwe tulinalikozesa linaakola ki. For example, tulina eddagala litera okukozesa ku prostate, baliyita finasteride, naye eddagala eryo likendeezaako ku maanyi g'ekisajja. So ekibeerawo oba olina okumanya, is it because of sukaali oba amadagala amalala genkozesa or things like that. Then treatment again is tailored to the problem. If a problem is lubrication, then we have some oils that we can use for the ladies. For the men, for example, if it is an issue of sustaining the erection, we give them again drugs to support and to sustain an erection. We have very many on the market, Viagra, and these have got to be used cautiously under medical guidance. so that we don't get an overreaction to the medicines. Then we come down to another notorious complication, diabetic foot. Once we don't control our diabetes very well, we get wounds on the feet. This time around, before, whenever I have such meetings, I normally bring those scaring photos with the gangrene here and there. But one time somebody discussed with me and said, you know what, you're over-threatening us. So this time around, I didn't bring any images of wounds that are gangrenous when the feet are going to be amputated. But by and large, under the diabetic foot, we have either, it can be an effect on the nerves supplying that foot, that the foot eventually dies, or it is a problem with the vessel. The foot is not getting adequate blood supply, or it could be a combination of the two. Most of the time, it's a combination of the two. The nerves are gone, the blood vessels are gone. Most of the time, if it is a nerve problem, somebody will tell you, Musawo siwulira, abigere sikyabiwulira at all. And these guys, basobola n'okulinnya ku misumali, basobola okulinnya mu muliro, basobola okulinnya ku bintu ebidamaginga ebigere byabwe nga tebamanyi. Some patients have gone into taxis, neyesigama engine, waliwo engine mu taxi, the engine is, the old version, the engine is in front, and somebody would put their foot onto the engine and it burns them when they don't know. So most of the patients who have lost sensation, they are bound to get neuropathic ulcers, wounds. And then the vessels, these are really because the vessels have been damaged and they don't get any blood supply, and then they become gangrenous. Most of the time, these feet become black because we maintain our color because of blood flow. Once you damage blood going to that particular foot, the foot becomes black and dies out. What is the treatment? Of course, it goes without saying, we need to control the triggers. We need to control our sugars. I told you the target. Our target should always be 6.5 HbA1c. We have to control our pressure, target 130 over 80. We have to control our weight. Weight target should be BMI of 24. Okay, but also specifically, we want to do toilet. Toilet is really cleaning, doing cleaning using our surgical spirits or the different reagents to clean up the wounds. At times here, we do even surgery, cut away the dead tissues from the ulcers. And most of the time, we take these samples for culture and sensitivity, but most of the time, we use broad spectrum antibiotics. Pentoxifylline, I mentioned this, it improves blood flow to that particular foot because it dilates the vessels. And then if somebody has got neuropathic pain, I told you these pains can be very notorious, burning, at times they get burning in the feet. Then we have to give them the drugs I told you, carbamazepine, amitriptyline, gabapentin. Basically the drugs, here we don't use our Panadol, our diclofenac, no. This is pain of nerves. Pain of nerves is treated using a different group of drugs, they sort of like work on nerves. And most of them work within the brain to control that pain. The carbamazepine, amitriptyline, gabapentin, pregabalin, and the others in that category. So having said that, let's move down into monitoring and how we follow up our patients. Number one, we need those blood sugars. We need to periodically monitor the sugars. The sugars will tell us how are we doing in terms of control on a daily basis. We may not have the capacity to control the sugars on a daily basis, but we can scatter them out over time. Number two, we need to do the HbA1c. We need HbA1c every 3 months, and that will give you the evaluation. The sugar will give you the monitoring. The HbA1c will give you an average. How have you been at the end of the day? This program, how are we doing in 3 months? So the HbA1c will be the one which the test we do to tell us how the sugars, how we are controlling our sugars. And I told you our target here is max 7%. And then we monitor for complications once every 6 to 12 months. And just like we said, these we do within the different systems. The different systems, we monitor them, and what we monitor in the different systems is different. For example, the eyes. I told you we didn't go into details about the eyes, but diabetes mellitus affects the eyes. It gives us cataract, it gives us glaucoma. It can make somebody go blind. So we need to monitor the eyes and go to and see an eye specialist at least once every year, worst case scenario. We talked about the heart, where we get high blood pressure, congestive cardiac failure. So we need to run at least an ECG at least once a year. We talked about the kidneys, where the kidneys are going to affect us. The sugars are going to damage our kidneys. So we need to run the renal function tests at least once every 6 months. And then we can do the microalbuminuria at least once every 6 months. Then we can run other tests like liver function tests, because the liver eventually will also get affected. And so we may need to run that at least once every 12 months. So by and large, we need a systems analysis. A systems analysis at least once every 6 months or once every 12 months. But out of all those different pieces, we don't forget the kidneys. Worst case scenario, we have to run the kidneys. As we summarize, what is the important message that we are saying is that number one, insulin, diabetes mellitus is either a problem in production of the insulin or a problem in how it is working within the tissues. Number two, once we have a problem with the insulin, we get damage to the different systems that are supplied with blood, because diabetes damages blood vessels. So it is going to affect every system which is supplied by blood, the brain, the eyes, the heart, the lungs, the kidney, the intestines, the reproductive system, the immune system, the skin, the muscles, the nerves. So every part of the body is going to get damaged. It is essentially caused by damage to the pancreas and unhealthy lifestyles. The unhealthy lifestyles are going to drive this damage. Obesity, hypertension, smoking, alcohol, the herbs, we talked about stress, all these are going to worsen the damage within the body. And then the healthy lifestyle models, just like we discussed last week, are going to be important as regards to control of our sugars within the body. And then the treatment, remember that the treatment that we are putting ahead should be personalized. And here we are saying that look into this particular person who is before you, individualize what you're giving them. And remember, within the treatment, we have to address what is their core problem. Is it the eyes? Is it the heart? Is it the lungs? And then we tailor that treatment, but putting in consideration the cost, the lifestyle, the weight, the effect on the weight, other illnesses this person may have. And then we also consider the age of this person, because you will have different targets. Thanks very much. That puts a little bit of summary. Diabetes is totally too wide. In terms of treatment for today. Thank you very much. Unless there are any questions, any comments, any supplements.
Barakallahu Fik, Doctor. Thank you so much for the wonderful presentation and the information that you have shared. Can you hear me, Doctor?
I was saying that it should be important for us to note that the different complications that I tried to mention a little bit, each of them is so detailed in how we investigate it, how we treat it, how we manage it. But I tried to really bring out the key ones that somebody can at least have a head start.
Naam, barakallahu fikum, Doctor. It's been very comprehensive, alhamdulillah. And in case of people who missed from the beginning, this recording is going to be there on Oma Connected YouTube and on Facebook. Dr. Wabade Chibuzo in the chat room, and somebody asked, what are those drugs that cause weight gain?
Okay, wonderful. Thank you very much from my brother Msitwa. Hope he's doing well. The drugs that cause weight gain. Now, all the drugs which are going to stimulate insulin production or improve insulin action, they are going to cause an increase in weight. Metformin is going to cause sorry. We talked about the sulfonylureas. Sorry, it's not the metformin. Forget the metformin. All the drugs that we mentioned, the sulfonylureas, glibenclamide, glyclazide, glipizide. Now, all those, we call them sulfonylureas, or other people may call it the pancreatic stimulants. So all they do is increase the insulin. Remember, we said insulin causes weight gain. So any drug that is going to stimulate production of insulin will cause weight gain. So glibenclamide, glyclazide, basically that category of drugs. And they are the ones that are notorious at causing hypoglycemia.
Okay.
Otherwise, the rest of the drugs that are sensitizers that just stimulate this insulin to work better in the tissues, the metformin, the DPP4 inhibitors, the SGLT inhibitors, the pioglitazone, basically all those will cause a drop in your weight. And that is the very reason why we don't want to use the ones I've mentioned, the ones I've mentioned that cause a drop in weight in patients with type 1. We don't want to use them in patients who are thin, because if somebody is thin, then you will make them thin further. We try to avoid them. Or if we use them, we use a very small dose and follow up those patients cautiously as we monitor the weight, because we want our patients to stay in a normal life bracket.
No. Okay, Barakallahu Fikum, Doctor. Brother Msitwa, okay, he's asking for your contact. Okay, I think he answered his question.
I was putting up a hand, Brother Yusuf.
Brother Sulaiman Suhuga, Chairman.
Assalamu alaikum wa rahmatullahi wa barakatuhu.
Wa alaikum assalam wa rahmatullahi wa barakatuhu.
Olwaliro omusomo ngumisiingidde ddala mbadde bubeezi nga kifaananyi eyo naye nga siriyo atola.
Sorry about that.
Just for the recording, he knows the recording.
Yes. Kati ebisomeseddwa simanyi oba kyengenda okubuuza bakyogeddeko naye nga ziri question bbiri kasooke n'akatono kubanga kano ke kaliidinga ku question ey'okubiri. Abaami n'abakyala ng'e Uganda ewaffe endwadde eno professional, percentage wise bakyala basinga obulwadde oba abaami basinga obulwadde ya diabetic? Then kijja kundiidinga question number 2.
So thank you very much, my brother. Olaiko obadde oli busy on table.
Yes, sir.
Now, what is important about baffe in Uganda and globally, about what they abasinga okubeera ne endocrine or hormone issues in
abuze
ddala obungi globally, even locally mu Uganda. Actually, number yabwe ebulako katono okubeera 2 to 1. Abakyala babiri ababa ne sukaali obeerayo n'omusajja omu alina sukaali. And of course, the reason for that, just okugattako akantu abantu bakategere why, the reason for that, number 1, abakyala balina hormone zaabwe, balina estrogen mu mubiri gwabwe.
Yes.
Estrogen oyo alina engeri akolamu nga steroid, oba kujjukira discuss steroids. But the estrogen, which is a female hormone, engeri gyestimulatingamu sukaali ne yeeyongera mu mubiri. So abakyala, by and large, because of that estrogen, balina risk nneneko ku basajja okufuna sukaali. The number 2, the rate of, still because of the estrogen, abakyala hormone yereba ebagezaamu okusinga abasajja botulira abakyala balina obesity neneko okusinga ey'abasajja era because of hormone eyo kati era singa olw'omubiri risk yaabwe ya diabetes neneko naye ate era n'ekirala abakyala abo balina health seeking behavior bagamba bangu amangu nyonyo ogenda mu ddwaliro zana abasajja tujja kwekunya weebuze naye mukyala owuliramu akagira amangu nyadduse agenze mu ddwaliro so tulowooza namba eyo tugiraba neneko because be basinga okujja mu ddwaliro okusinga abasajja tulowooza abasajja abali sick basigalayo mu community so ako nkongeddemu just abantu bakitegeere also perspective eyo.
Kakati ekira ekiddako waliwo ka clip akatambula ennaku zino ssebo tweyanziza ku ansi eyo omusomesa waffe omusijja kwogera linnya kubanga chef nga agamba nti ekiyambako ku musajja senga alinaku omukyala asukka mu omu okuba ntajja kulwala ndwadde nga zino waliwo evidence y'ekintu ekyo oba just assumption oba munamumbala tuba abantu bawulina be baami nga bamukyala omwomu oba abaami
doctors mami nsuka birese mu sukaali
anti sheki yagambye oba yagambye yasomesa yagambye nti oli waba asussa bakyala abasukka mwomu sukaali pressure ndwadde zabadde nga ssatu zeyayogedde chances zikendera yes olwokuba omuntu abeera active maybe that can be an argument naye kati on your experience kubaami
thank you very much ngenda kikwera mu perspective eno
sorry
it is like this diabetes mellitus by and large ejja kujjanga ebintu bingi ebyegassa awamu senga mbeera n'abakyala babiri no doubt activity yange ebeera neneko I will have more activity. However, ekyo kyokka bwe mbeera nga kyokka kyekiyimiridde kyokka nja kubeera nga ndi risk yange ya diabetes ne pressure ne cholesterol n'ebikintonoko. However, senga mbeera n'abakyala babiri ate nenstimulatinga ebirala ebireeta pressure ebyongera okutawaanya pressure. For example, nzoba nina abakyala babiri naye gate ndya bubi. Nga ndi ebintu ebisiikira byama nkoko distressed ngoba nina oba kati abantu abanywa omwenge oba nywa sigala oba kati abantu nga kati ogattamu ebintu ebirala biyinza okukendeeza effect ya activity eri gyemafune but by and large bwoleka just ekyokubeera n'abakyala ababiri as a stand alone it should be giving you a reduced risk of those diseases. However, tulina okitunuulira together n'ebirala ojoginga muko diet eri etya stress levels ziri zitya pressure ziri zitya tulina okitwala together together.
Inshallah doctor barakallahu fika. Kakati waliwo yabuuzizza Shekali yabuuzizza nti lwaki obulwadde tubuyita diabetes ne mu Luganda ne babuyita sukaali lwaki babuyita sukaali?
Change ogambako to that is that lwaki mu Luganda bakiyita sukaali is because sukaali aba akyankalanye nti sukaali aba mungi mu mubiri kyobulaba nga mu Luganda tukiyita sukaali because sukaali aba ali waggulu really kyebeeranga bwogamba nti omuntu alina pressure era pressure eba erinnya ngoba bwogamba nti omuntu alina alina ensigo so depending to ki ekirwadde kati mu bulwadde bwa sukaali aba akyankalanye mu mubiri gwaffe nti sukaali ono omubiri tegukyasobola kumukendeeza abeere mutono kyobula nga bamuyita sukaali.
Glucose tumuyite nti ye sukaali mu Luganda.
Glucose ye sukaali. Glucose mu Luganda ye sukaali.
Okay. Akawoomerera ako ye sukaali.
Saagala gamba kawoomerera.
Anti bagamba nti sukaali. Bagamba nti yalwadde sukaali ne sukaali lwe mukujjako kuba awoomerera. Kakati beebuuza.
Bebanaagenda by terminology nti ekiwoomerera.
Tulina
ebintu bitawoomerera naye ng'ate biyinza okulinyisa sukaali. For example, nja kuwa example, twakola study ne tukizuula nti nno akawunga kalina sukaali mungiko okusinga serumonde. Naye ate lumonde awoomerera okusinga akawunga.
Really?
Yes. Twakola study ne tulaba nti obummonde Irish potatoes zirina sukaali asinga amatooke. Naye ate bw'olya probably amatooke gayinza okuba gawooma okusinga Irish potatoes. So badde saagala nnyo gamba nti ekiwoomerera. Sukaali aba sukaali. Ekiwoomerera kati oyinza okukozesa Stevia.
Yes.
Stevia. Kawoomerera naye ng'ate kajja kutawanya sukaali wo at all.
Okay.
Yes.
Okay, barakallahu fiik, Doctor. Abanaye mwanike emikono for people abakyalina ebibuuzo.
Doctor.
Okay.
Doctor, assalamu alaikum rahmatullahi wa barakatuh.
Assalamu wa rahmatullahi wa barakatuh.
Doctor, mbadde njagala onyambe o sensitizing abantu as well regarding omanye waliwo ekiri mu society yaffe nefanze wemba nina sukaali ne doctor nangamba nja kumiranga metformin oba ampe ne glycoside kati hasifa najja afuna sukaali hasida amugamba alina sukaali nga mugamba abagambye olina sukaali nti ye naawe emira lino lyemmira
mino.
Now that is also an issue gender byeri mu bantu baffe tebaagala bakebera naye nga twandibadde tubabuulira nnyo nti buli muntu is an individual nti balina kusooka kubakebera not kugendera ku ddagala ono alimira lino nange kammire lino no n'abeera mu family n'abeera abantu nga 8 naye nga eyasoose yalinze kagala ne bankebera.
Thank you very much. That's a very important point, Jolese, because abantu baffe most times actually waliwo abajjanga oli couple husband and wife nga omusajja awako ono kadagala ke ono akono bekaggwaho ono nawe wakoona akake. Now that is totally wrong. Now diabetes is a special illness era twalifubye nnyo nga bwe tusobola. At least noberanga you get in touch never experts in this area because olaba bulabi ngaffe abakuwa eddagala naye eddagala eryo bw'ojja mu ddwaliro as I speak to you bamaze okulaba muli mu kigwokola ddagala lino benaalikuwa linaakola litya oyinza okuba olina asima oba eddagala limu terikwatagana ddagala lyolimira oba olina for example activity gyokola katola eddagala limu nga tulimira ku makya kwokka tugenda ddimira kiro tulina obuyisa obwetwekuba obuyisa bwa kiro nga tugenda bukuba ku makya kati ogenda kukola ng'olya sikaali n'enkuwa insulin nga nze manyi olya sikaali ate gwe insulin omu n'okwata omuntu omulala n'omumuwa ate ye nga takola kiro okugamba eddagala eryo tugenda oddiwa omuntu tuba tumaze okulabira ddala nti omuntu ono alina pressure oba ensigo ndwadde oba ekibumba kirwadde oba kino kiriko kino n'enkuwa eddagala nga mmaze okulabira ddala nti eddagala lino lyono so kati gwe olikukwata n'oliwo omulala oba okoze ensobi nnene. Buli muntu alina ebintu ebimukwatako byanjawulo nnyo. Ekibagatta kibeera kimu nti mulina diabetes mwenna, but that diabetes ayinza n'okubeera nga ali different ng'owono type 1 owono type 2 oba nga linamu enjawulo munda omwo oba nga omulala alinamu n'ebirwadde ebirala. So tufubenga bwe tusobola eddagala eryo tetuligatta at all. Mpozi nga oyinza okubeera nga really oli abadde akozesa katugambe bampa metformin nawe bakuwa metformin nga doozi ze zimu. That's okay, it's understandable nti metformin kankampeddeko mpakkako, that's understandable. Naye okubeera nga baakakuzuula tolabye na musawo tomanyi eddagala kiri ogenda kukozesa n'okwata bukwasi kali n'omuwa ku kako k'obadde okozesa, it can be totally dangerous. Osobola okuleetera omuntu obuzibu ddala because buli omu abeera eddagala tutunuulira omuntu oyo gwe tuba tugenda okujjanja tumukolera package eyiye.
Doctor, ate the sensitization kuba pharmacies ez'okukyalo kati nga kummwe abasawo okwongera okusensitizing aba pharmacies abamala gagaba eddagala Komanga omuntu ajja mu pharmacy n'agamba sukaali yalinnye n'agamba muwe kana akalagala. Kati ate abo bo mukoze batya mu abasawo abakugu okwongera okusensitizinga abo abantu ab'omu pharmacy abakola abamala gagaba eddagala.
Bali banoonya ssente.
Now ideally, omuntu yenna nga oli ng'ogaba eddagala lya sukaali libeera mu category omuntu alina okuleeta prescription. Omuntu aliba alina okuleeta prescription because lwaki aba alina okuleeta prescription? It can be a very dangerous drug. Osobola oddiwa omuntu ne limutta n'okumutta. So toyagala kuliwa muntu, toyagala ddiwa muntu just because azze ayagala alina sukaali n'omuwa wuli nedda. Actually mu Uganda somehow ekintu kyaggwawo nti omuntu ajja ayagala ddagala lya pressure ne bamuwa buwi. Ono azze ayagala whatever ne bamuwa buwi. Ya doctor kati amadagala ga sukaali galina kubeera mu category ya galina okujja ne prescription ng'ovudde wa doctor. But unfortunately system zaffe tebamonitoringa nabo nga oli mundani ffe bagambye baagala ssente. So onojja bagamba oyagala kadagala kyanga metformin galikuwa kumbe omuntu nga yakutte glibenclamide. Okimanyi bulungi glibenclamide twamukozesanga n'omukozesa okutta emmese. Kati bw'okwata glibenclamide n'ofaga muwa muntu, it can be a very dangerous drug omuntu afa galikozesa ffa. Ate lisobola okuleeta sukaali nakkirira ddala ku speed. So pharmacies of ideally lwakuba systems munnange zibuzibwe ez'e Kampala. But I'm sure in Europe nawalala where things are developed bagezaako agati nedda naye omusawo akuwandi olaba ne bojja buzinika prescription nga kakadde kati ddagala erikuwandikira mu January nojjanga kaakati ng'okaleese. Developed countries tebajja ddikuwa eddagala bagamba nti musawo yagamba mwezi gumuddayo omulabe.
Era ne bwe likuggwako nga tokyalina refills olina okuddayo w'omusawo to get an appointment addemu akebere kidney function zona buli kimu kyonna okuddemu okulaba nti prescription is the right prescription for you.
Thank you. Can I go to the other question? Ugamba doctor. Ogamba nnyo abantu, especially with diabetes, is that their medications, obviously, it does affect the kidneys. Metformin does affect the renal function of some patients. Until they have to be checked. Naye abantu baffe doctor, tunaabateekamu tutya nti waakiri mu myezi 3 jangu bakkebere.
I think by tulina kiteekamu mpola abantu batandika okumanya nti they must always create a budget aside. Nebeerawo nti budget nga bwe budgeting nti zino sente za investment, zino za kusavinga, zino za baana kudda ku ssomero, walina okubeerawo a portion that is assigned to illness. More so, wabera ng'olina chronic disease, kiba kitegeeza now it becomes even of paramount importance because ogenda kyetaaga by almost tugambe by force nti olina okukebera systems. So I think abantu baffe kukimanyira nti we must create a budget for our health even before illnesses come. Tulina ogiteekawo as a routine ekizibeera nga zibeerawo at any one time. Then number 2, waliwo omuntu alaze wano nti no does irregular blood sugar. That was Najib. Does irregular blood sugar levels mean one has diabetes? Twalabye last week nti omuntu yenna as long as level yo tesusse levels zetwayogera HbA1c togenze above 5.7, fasting blood sugar nti tosusse 110 fasting blood sugar, then random blood sugar tosusse 140, then oba toli mu bantu balina impairment. Kati ate bw'osukka ezo figures embabulidde awo boogenze mu impaired bracket budde beetandise okuwuuninga kasosuka fasting 110, HbA1c nesuka 5.7, random nesuka 140, oba oli mu impaired bracket. Kati ne bw'obeera ng'oli irregular naye ng'oli below those cut-offs, that is okay. the sugars can always vary. For example, you call random, maybe 120. Enzamu random endala ngandi ku 130. Enzamu endala ngandi ku 100. Those are okay as long as I'm below the 140. Now, yes, suka 140, chiwa chitegeza ungenze mu danger zone. However, twagamba, you don't rely on a single reading. Sengo somo lwalero figure neberanga esussemu. Kozesayo another parameter owajiddemu yennyini after some time. Okay, at least 2 readings. Is supporting your abnormality. Beberemu oyinza okweranga olw'ekibaddewo oneddagala okusana ekyankanyamu sukali. So you want to be sure this is a true rise. So you want to then go against above cut off the twayogedde. And nagamba somebody has again Najib has said ewaffe mukama yatuyamba. Yeah, about the different parameters. Some places are very lucky, like I think in Britain and even somewhere in the Arab world, abaradde sukari, they give them everything free of charge. They don't pay even a coin. Somewhere, I think Algeria, Morocco, Saudi, I don't know about Saudi Arabia, but I know about Morocco, Algeria, they give them everything, glucometers, strips, amadagala gonna naga kafuruma, top of the range medicines, all these long-acting insulins, they're given to them free of charge by government. But if you come to countries where people are struggling to get paracetamol, struggling to get treatment for malaria, then they have to buy the drugs for diabetes.
No, barakallahu fika, Doctor. Sister Habibu, the co-host. Sister Habibu.
Warahmatullahi wabarakatuh.
Alaikum salam wa rahmatullahi wa barakatuh.
Barakallahu fika, Doctor. Tuyanze. Ekibuzo kyange kiri ku Herbal Meds. Last time kale wakyogerako. Naye kati waliyo abantu abo abakozesa Herbal Meds oba these Arabic medicines eziri natural. Abamu ne ba confessinga nti bawona. Naye kati abantu style eyo wandibawadde magezi ki kuba kati ate omulala ayinza olikozesa nga ngeri gye litaliiko kipimo ngera bwe twagamba. Kati abantu abakozesa ebyo nga bo babinyikiramu basically oba wamagezi ki at least babeere nga ne mu ddwaliro bagenda beekebeze alaba oba yeeyongera oba waliwo enjawulo wandibadde obayamba otya kuba waliyo abantu bonga ebyo byo bye bakozesa oba bye balowoolezaamu nti biyinza obbakolera.
Now, what I've been telling my patients and what I tell them is that, number one, there is no single herb or muntu jagenda okozesa that is going to help them with diabetes. Amadagala agamu ge bagamba katugambe aloe vera, some supplements, they help the body. They help the body generally, whether you have diabetes or you don't have diabetes. When you're aloe vera, it is a supplement that helps the body. But anything, carotenes, it helps the body. If you take anything, selenium, different components, zinc, vitamin D, bingi ebiyamba body. However, there is no single herb that is going to take away diabetes. Abalwadde bangi nnyo bafuna, they come back here. Unfortunately, they come back when the systems are damaged. And at that point, so message abantu baffe balina okukimanya nti herbals tezikola in terms of okutwala diabetes. They just help support the body. Nobody doubts the fact that they support the body. Gabula abantu mulwadde ayinza oba alina HIV, alina asthma, alina pressure, bamira supplements. Those supplements will certainly support and help the body, but they don't take away the disease. Disease diabetes yetaga lifestyle, even before the medicines, lifestyle. The marriage tuya, just like we discussed, the exercises, the weight control, those parameters, they contributing to a tune of 60% plus in terms of controlling diabetes. So for starters, we need to adjust the lifestyle. Then amadagala gakwatirizaako ku lifestyle. And of course, omutasooka time amadagala ne governor kono linasigala ku lifestyle. I've had so many patients, endless, that have gone off medicines, but it doesn't mean the disease has gone. It is just gone into remission. Them because lifestyle ebadde nnungi. Then number 3, abantu abamu bakwata amadagala nga metformin oba glycoside ne bagayiwa mu ddagala area local. You know, Google people can go on Google and Google. So oli ajja kukwata a herbal medicine aliteekemu modern amadagala gana amalala alina kulaga nti sukaali akendedde. However, that abataddemu eddagala, that is even more dangerous because tomanya interaction endala gye zikola, tomanya kibeeramu munda. But many people, I'm sure if you've been reading over the mawulire oba ku media, mulabe bangi nnyo abantu basazaamu amadagala bebagira nga bagattamu amadagala. Oli akwata eddagala n'ayiwamu eddagala eddala. So you will see effect, but that effect is not because of the herb. It's because you're combining the herb plus metformin. But by the downside to it is the damage to the systems. These chemicals cause damage. You take herbs, they damage the systems. Era omuntu yenna agamba nti amusawo nze njagala kunywa akadomola kange kagamugamba fine, genda maaso n'akadomola ko. However, buli myezi 3, make sure you are checking. I want your HbA1c, I want your liver, I want your kidney, I want your heart. The different systems of current zero on track. Because when you close out, you're doing good, negative systems are getting damaged.
No.
Barakallahu fik.
Doctor, I have a question about dialysis. Ogambie, okay, when people are in that advanced renal failure, betaaga dialysis, naye engeri expensive. Omuntu wa bulijjo akoza atya? Eddagala liri expensive. Kati atuuse mu acute renal failure yeetaaga dialysis. Naye $5,000 omuntu wa wansi akola atya?
It is very sad, but surprisingly, if we do a good job, sukari netumu controlling ale, the medicines are affordable. As long as, unfortunately, lifestyle is very hard to sustain. Most people don't do the lifestyle. But if you do your lifestyle, the metformin one bisatu, maybe another drug which may be like maybe say 500 or 1,000. So no sanganga, you know, you find a bill that you're incurring, but once given the bill, face. Actually, if you go into dialysis, you multiply your cost by not 20 times plus. But dialysis is guru because if you matwina solution that cleans up the blood, because ensigo bezifa ensigo ezo zirina okusengejja kachacha inali mu mubiri kati bezifa ekyuma kye kibeera kisengejja omusaayi gwe guyita mu kyuma ekyo ne bagusengejja ne gukomawo sukali avuddemu ne kachacha omulala kati ebintu ebyo tukozesa ka filter waliwo ne solution eyo gye tukozesa ya bbeeyi, and most of them are patented. Abantu bazipatentinga patentinga kitegeeza nti waliwo omuntu eyagizuula alina okufuna ssente buli lwe batunda solution eyo. Kati omuntu oyo unless bamuconvinsinze oba era n'abeera nga ssente zikka wansi oba kininga bantu individuals naawe nga babakidiscoveringa kati aba asigala afuna ssente zoba nga cost esigala eri waggulu. Kuliko mu parts kumpi weranga 6 ne bonna abantu bali different ababuzuula balina okusasulibwa ku cost eyo. Ate ya Uganda y'emulago eri kale ne bw'ogenda mu private sector that cost goes up by 3 times. Wanga y'emulago government yagisubsidizinga eri wansi ku ddala. Era almost bw'ogendayo ebeera ekola 24/7 ekiro basigala bakola throughout the night kubeerako abantu abali ku machines. So kiba kitegeeza tulina okwencouraging abaana baffe bafune engeri gye badiscovering machines that can clean up the body quickly, cheaply. Naye nze ndowooza because tetuteekayo mwoyo ba scientists because when we twafuna COVID, people discovered machines is oxygen. Machine yemwe egula kumpi million nga 2. Nika ba discovering machines nga zigula just million nga 3 million 5 machines nga zikola omulimu gweri machine ya million 3 gwebadde ekola. So nekino senga abantu bakiteekako obwongo n'ekirowoozo basobola okufunayo ebyuma ebisobola okunaaza omubiri ku cheaper price. But having said that, the important part tulina okwekebeza. Twagamba last week wofuna ka chance kono ogenze mu ddwaliro bakebera omusaayi. Sukaali ali very cheap to test. It is the cheapest test. Ndoze eringa kumpi ne malaria. Omusulo ne malaria ne sukaali ebimu ku cheapest test gy'oyinza okukebeza. Nti banayinza kunkebera ka sukaali. So wofuna opportunity yonna ne bwoba wakakoze wiiki ewedde ne wakakoze omwezi ogwawedde wofuna chance nga kebera ka sukaali. Ogenza okukyalira mami oba senga oba kojja ina akuma akapima sukaali mugabe wayi kebera ka sukaali tulabe. Musawo yangamba cut off eri wano. Then ababadde babeera discovered nti balina sukaali tulina okufuba nga bwe tusobola abeere controlled. Lifestyle yaffe tuba tulina ogikyusa. More important actually n'abatannaba mufuna lifestyle ogitandikirawo. Exercise ezo nga bwe twagamba week n'oddukayo n'okola exercise 150 minutes per week. N'ogezaako akamere kaffe nga bwe kutwaka discussing okasala discussing okendeeza the stress ne other factors obunene. Ebyo byonna tulina obifuulwako nnyo so that tetugenda mu dialysis. Tuba tujja guma tuspendinga akasente akatono kano tuleme genda mu cost ya dialysis.
Dialysis is expensive everywhere.
Wanji?
Dialysis are expensive everywhere.
I know it's expensive. It is expensive everywhere. And I mean, I see people here, they do get treatments even if they don't have insurance. When you are in Uganda.
Sad.
Actually, in developed countries, I think dialysis, in the UK, I think it is part of the national program.
Yeah,
US,
and it's 3 times a week.
Yeah, no wonder it is 3 times a week. It's 3 times a week. And if you don't have insurance, you still be dialyzed. Yeah.
So one bagezako kuleta health insurance, national health insurance. It's in pipeline. I don't know how it will work out, but even then, you have to take such things. Things are covering dialysis. It will just cover the usual basic illnesses.
No.
Yes, in the UK it is free, as you say, it is free. But we in hospital get patients that come in, are better private. And it's very, very expensive. Even just a bed on a normal ward, it's expensive. It's about £300 a night, and that is a general ward. Ne wogenda on sort of like special, 300. Wogenda ku specialist units like CCU cardiac units. You're paying £500 a night. That's a day for people who come in private patients. Yazeku holiday na rala na I know where admitted. So we do the calculations. It is expensive.
But that means it is cheap in Uganda, because in Uganda,
when we calculate, and this is a local hospital.
Compared to anywhere in the world. It's just that
I know.
And what Gambi wano mwavu wakufa Uganda.
Tulina kulya nnyo bugga ne nakati ne katunkuma ne biringanya ne cabbage ne karoti etudduka emisinde.
Inshallah. When anybody else has a question, the Dr. Tucha Molina, this is the last session between diabetes. Mamine chibuzo mwaniko mkono. And so we can ask the doctor while he's still here with us.
What about our government, for example, what talk let me also throw some light on that. What about talk about misleading the public? Tina Madagala, Womira Madagala, metformin for long, Womize, any of glycoside, over any of the drugs for cigar. Ntigalina, the herbalist bagezako kulaga nti kano kajja kuyisa bubi jangwe no ku herbs. But again, to throw more light on that, amadagala gonna gawa side effects ki, gakoze ki, what are the effects galeeta ku mubiri. So eddagala lyonna lyonna lye bazuula nti lirina akantu konna akatali okay, balijjako, bali recallinga ne balijjako bataddamu reproduce ne baddayo ne baditereezaamu. So there's always an ongoing, amadagala ago bagatunuulira. Wadde eddagala libadde ku katale kati nga metformin era basigala bamwekebejja okulaba alina kyaleeta ekibi, alina kyaleeta ekibi. So bwabeerawo kyonna ekiriwo nga bamuggyako ku katale. Of course it has to reach a certain level ne bakakasiza ddala nti yakireeta, then bamuggyako ku katale. So people should also have that confidence that these medicines are following up closely okulabira ddala nti tegaleeta bulabe bwonna eri bantu. Okay.
Dr. Nseka nazibibuuza biweddeyo. Waliwo abuuzizza wano privately, what is the milk effect on diabetes?
Milk. Twayogera ku diet the other omanya America bemera mwogera tulina okuwuliriza obulungi ab'e Uganda.
Siri mu America, doctor. Siri mu America ne Uganda.
Naye ati era bw'ogendeyo n'obeerayo for some time nga toni ekyuka nga nawe because of olina okwogera ne bakuwulira, so you speak like them eventually. But milk by and large amata tegalina kakwate na sukali directly. Amata gaffe twagamba tunywa amata. However, having said that, amata gasobola gabeeramu ku masavu, gasobola okugeza bw'onywa amangi ne gageza ne gakuleetera obunene obuyinza okuaffectinga sukaali. Katugamba nti kiki tugamba nti amata bw'oba oganywedde gezaako nga bw'osobola oleme kunywa galeme kubeera too concentrated. Twali tugambe okola ekikopo kimu eky'amata n'oteekamu kimu eky'amazzi. Then number 2 ne tugamba nti amata ago tokiyitiriza kubeera nti oganywedde ku makya, oganywedde ku kyemisana, oganywedde ekiro, ogazzeemu luli. So you try and scatter it out. Nobeera nti tonywa mangi nnyo. Naye ng'amata by and large bw'oganywa nga kaakati sukaali ng'abadde nga ku 5. N'onywa amata ayinza n'obutakyukako ate olwo. Oba n'akyukako katono nnyo nga taweza maybe na unit. So amata effect yaago era body zonna za-advising nti omuntu yeetaagayo eglaasi y'amata. So amata tegalina effect malungi actually for the body. Galina nutrients nyingi nnyo. Amata n'amagi ne liver bye bimu ku bintu ebirina nutrients ez'enjawulo ze twetaaga mu mubiri, kubanga ekibumba kye kitereka buli nutrient gy'omanyi mu mubiri. So ekibumba ekyo kirina kiriisa ky'amaanyi. Then n'eggi lirina buli kiriisa, then n'amata.
Dr. wano bagamba egg whites.
Yes. Anka bw'olya kali ak'omunda oluusi kabeeramuko ku masavu.
Cholesterol.
So bw'oyitiriza okulya amagi amangi nago gayinza okuleetamu ebyo byonna bye twogedde, liver n'amagi n'amata gayinza okukuleeteramu ku ka cholesterol. So obikozesezza olina okubiminimizinga n'amagi n'olemba gasiika.
Naam. Barakallahu fiikum. Mbadde njagala ga Brother Musitwa obadde ogamba the recommended summary and the recommended diet. Mbadde ngenda kusaba oba ogende ku Connected ku YouTube. The first session eya doctor yali extensive ku diet. Mbadde nsaba referring on to that kubanga yali detailed. Ayinza butasobola kugiddamu essaawa zino. Najiba agambye eddagala ettuufu Uganda gye liri kubanga erisinga liva India. Bagamba erya India lusaabulukufu.
I think what is important is that amadagala actually of recent, most of the medicines, at least luli twalinga mu Europe wafuna eddagala ne tulifuna after like 20 years, after 15 years. Naye kati amadagala agafuluma gajja wano relatively within a short time. Of course, kitwalamu emyaka ng'ebiri beeriti esatu odifuna. Naye abayimbi tulina linnya eriva mu India. So e Kampala tulina eriva mu Europe, tulina n'eriva mu India. Kati eriva mu Europe because liba likyali era nga livudde ddala nga ekinyusi kirungi, bbeeyi yali ebeeramu waggulu, eri India lijja kujja nga ebbeeyi erimukko wansi. Naye kati omulwadde omunnyonnyola n'omugaa nti owaayi waliwo lino waliwo ne lino. And usually eriva mu Europe usually liba lijja kubeeramu waggulu mu kabeeyi. But of course libeera superior to the ones that come from India because of certainly mu Europe bafaayo nnyo regulation. Ogambye mulimu ekiriisa kino mwekiri, ogambye kino kiri ku 90%, kiri ku 90%, yet mu India probably the regulations ziyinza okubeera obutabeera that strict, kulabira ddala ku following every whatever erifuluma. But omulwadde usually tubabuulira omulwadde n'asalawo. But in Uganda amaddagala mwegali kaakati pretty well. N'ekyalo ekirungi kye twafunamu nti most of the multinationals, they gave up on most African countries and particularly even including Uganda. Kati basalawo Uganda ne basala amaddagala ne baba nga tebagafunako magoba, baba nga abatuwa donation. For example, Novartis, Novo Nordisk, abakola insulin, waliwo aba Maxerono, bonna basupplying amaddagala mu Uganda at a really subsidized rate. So we were able to get European brands at relatively unaffordable price because the manufacturers decided not to make a profit out of the market in Uganda. They just keep it at low cost.
Okay. Barakallahu fikum. Those are ebibuuzo byammwe. Dr. Sina ekibuuzo kirala. I guess for me, my final question is going to be, how do we sensitize abantu baffe, communities? Twongedde tutya okwongera okuba sensitizing, like on radio and TV? Tukoze tutya okwongera okuba educating ku awareness eya diabetes, obutatuuka ku one, obutalemera nnyo ku herbal medicine, obutalinda obulwadde bukule batuuke mu renal failure. Tukoze tutya okwongera okusensitizing community yaffe? Oba how can we partner with the doctors nga mmwe okuyamba abantu baffe?
Jazakallah khair. Kakati unfortunately nti tuli batono ba experts ba diabetes, tuli batono mu Uganda. Tuli, what can I say? Tulina omusawo amutikka ebintu bingi. For example, myself, ojja kusanga a lecture with Makerere. I work with Mulago Hospital as an endocrinologist. I run my own private clinic. I run the outpatients within the Mulago Hospital. I see the inpatients and the outpatients. So kakati osanga omusawo nga ali stretched so much. Nga kwataganyiza ebintu bingi. So nosanga nga time jajja okufuna ogenda ku radio, ogenda ku TV, ogenda ku mawulire, ogenda ku mu community obanga partners over ne organizations like you people. Nga omusawo nga ali so stretched. But like this one is a very good starting platform where we can always get to the people as much as we can. Really, it's just about we shall keep knocking. Kyali badde kirungi nnyo nti oba twalifunye engeri, for example, nga waliyo oba ng'embaga, oba waliyo oba kwanjula, oba kuki, oba mu mosque ngaawo, gamba twalifunye how we integrate the health education into all the other aspects abantu we bagatharingira. Nti abantu bagenda gatharinga, tulinayo platform bagenda kuyiga ku financial management. Natubagamba nedda abana emanyi as an opener, omusawo tugenda kufunayo ka clip kano mukawulirize dakiika ng'oba 5-10. Tugenda kati I was so impressed by the Kalisoliso in the morning. I usually listen to it as I drive to work. Naye bagezaako nnyo balina ka part ke bateekamu ne bagamba abantu bannange mwekebeze prostate, bannange mwekebeze HIV, bannange mwekebeze sukaali, bannange mwekebeze, these days they are talking about the vaccination for COVID. Because waffe tukyalinga ku 50%, twagala kuitinga 70%. So bagezaako to throw in 2 minutes about health mangu nnyo, but we should also push it further into the different platforms, TV, radio, different abantu bonna etusobola bakwatiriza, but ekirungi kasa mutandiseeko. It's a good start. We can pick it from there and propagate it further.
Inshallah. Ate n'omulembe gwa social media tubeera ne buclip nga buno ne recordings nga zino, we can easily share them. Ategedde nga akasharingako n'omulala.
I think kyetujja n'okukola ekirala is that we can come up abantu omuntu katokuliza. My talk has been running, we've been running almost close to 2 hours. Kati omuntu kiwuliza kyonna kibeera kinene. Maybe ne tujja ne tufunayo ka clip nga katono. Ne kabeera nga kali only like say 1 minute, because abantu e Kampala ebintu biwanvu olwasa kisuka eddakiika 5 abatajja kiwuliza kyonna. Kati oba yeetaaga akantu akali short like 2 minutes oba 1 minute, between 1 to 2 minutes. Olina nga message agifunye ne tu developing something like that.
Inshallah. The experts are a computer. Brother Osama, you know you can do it. Inshallah. That's a check at each bibuzo birala.
Okay, mashallah.
Sister Neofano, zangena kwa kazinda lo Dr. Mwebas closing.
Dr. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam wa rahmatullahi wa barakatuh. Nilfa deliberately decided not to put her video.
Doctor, forgive me.
Okay, I've forgiven you.
I did a night shift, so I'm not in that good state.
Okay.
Yeah.
Again.
Thank you very much. I know you're going to, obviously we'll call you back.
No issues. I'm always ready for you guys.
Tusomera tuyize era ne tusaba abantu baffe bonna abali kuno tubasaba to educate more people. Let's just do more health promotion as well, like Doctor is also doing and saying. Your doctor sina nyo asfa ya basi nayenga. We'll see you inshallah. I'll be in Kampala soon inshallah.
Inshallah ta'ala. No facho yoge desija kuchidamu. Dr. Tukwebaza, we are truly humbled of squeezing your time in your busy schedule ngabo tugambye. Ne Imam Kasozi tumwebaza wedda kwali nendo zakati avuddeko okubanga yasobola okutugamba nti Dr. Mutebi is wonderful, naye tumwebaza. We are humbled. We'll keep knocking tutukowa.
Keep knocking.
Tusaba Allah kusime akwe baraka mu riziki yo mu kusomesa ko in your businesses and everything. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam wa rahmatullahi wa barakatuh.